Are we using biologic therapy properly? The introduction of infliximab, Remicade, the first biologic therapy approved for the treatment of inflammatory bowel diseases (IBD), did not result in lower rates of hospitalizations or intestinal surgeries among patients living with IBD in Ontario, according to a study published by authors from several Canadian hospitals and ICEs in the journal Gut. The authors studied trends in hospitalizations, surgeries and drug costs among individuals with Crohn's disease and ulcerative colitis, collectively termed IBD, living in Ontario between 1995 and 2012. They compared trends following the introduction of infliximab in Ontario to trends that would have been expected had the drug not been introduced. Infliximab is a type of anti-immune anti-TNF therapy that blocks inflammation in the gut and other organs. It is used to treat a variety of inflammatory diseases and became available in Ontario for Crohn's disease in 2001 and for ulcerative colitis in 2006. The researchers found that even among people with Crohn's disease who received infliximab, there were no significant reductions in disease-related hospitalization or surgery rates compared to what would have been expected with conventional therapies alone. People with ulcerative colitis who received infliximab also did not experience lower surgery rates, but they did see some improvement in hospitalization rates following infliximab introduction. These findings are disappointing for a class of therapy that has demonstrated benefit in reducing IBD-related hospitalizations and surgeries in clinical trials, said Dr. Sanjay Murthy, lead author on the study and an IBD specialist and associate scientist at the Ottawa Hospital. We had expected to see larger declines in these adverse health events because they are more common in IBD patients with severe disease, and these are the same patients that we should be targeting with this therapy early in their disease to prevent hospitalizations and surgeries. The study did not take into account the impact of this therapy on other important health outcomes, such as quality of life or workplace attendance and productivity. Clinicians have seen how anti-TNF therapy can dramatically improve their patients' symptoms, and in many cases even lead to complete bowel healing, said Dr. Murthy, who is also an assistant professor at the University of Ottawa. But even though the drug clearly helps some individuals, we are not seeing some of the important benefits we would expect at a broader population level. This suggests that we may need to improve how we are using this drug in clinical practice to realize greater benefits. About 270,000 Canadians live with IBD, and the rate of this disease is rising in Canada and around the world. The direct healthcare cost of IBD in Canada is estimated to be $1.28 billion annually. Some of the most significant health effects of IBD are hospitalizations for severe complications and intestinal resection surgery to remove diseased bowel that is resistant to treatment. The study further showed that the average per-patient drug costs for IBD have risen dramatically since the introduction of infliximab, particularly among individuals with Crohn's disease. For patients with Crohn's taking infliximab, average annual publicly funded drug costs rose from approximately $1,000 before infliximab introduction in 2001 to more than $14,000 by 2012. For ulcerative colitis patients taking infliximab, the mean drug costs rose from approximately $2,500 before infliximab introduction in 2006 to more than $10,000 by 2012. The researchers estimate that 25% of patients with Crohn's disease and 8% of patients with ulcerative colitis would have received infliximab by the end of their study follow-up. Anti-TNF therapies are substantially more expensive than conventional therapies for IBD. As a class, they make up the highest proportion of public drug program spending in Canada, at 8.7%. The researchers hypothesize that selecting the wrong patients, delaying the start of treatment either by not recognizing disease severity or through poor access to treatment, and incorrectly optimizing drug dosage could all be factors limiting the real-world impact of anti-TNF therapy at a population level. Criteria for reimbursement through public or private health insurance may also limit timely access to the therapy. However, the researchers also noted persistent declines in hospitalization and intestinal surgery rates across the IBD population well before the introduction of infliximab, suggests that improvements in traditional care were already having a significant impact. In addition, annual bowel resection rates among IBD patients were already low in Ontario at the time that infliximab was introduced, about 4% for Crohn's disease patients and 2% for ulcerative colitis patients, which may have left little room for further improvement. While it may be disappointing that this therapy did not impact IBD hospitalization or surgery rates across Ontario, this doesn't mean that it is not impacting individual patients, said Dr. Murthy. Further research is needed to study quality of life and workplace productivity to capture the full breadth of the effects of this treatment in Ontario and in other provinces. However, our findings suggest that further education of clinicians and patients is needed before this therapy can realize its full potential. Lowering cholesterol is not enough to reduce hyperactivity of the immune system. Hypercholesterolemia is a major risk factor for cardiovascular disease. Statins are the most widely used cholesterol-lowering drugs. However, despite treatment with statins, many patients with elevated cholesterol levels will still develop cardiovascular disease. Currently, it is apparent that not only cholesterol but also the immune system plays an important role in the development of atherosclerosis, but how cholesterol and the immune system interact is still unraveled. A recent study from the Netherlands now provides a novel potential explanation for this residual cardiovascular risk, related to persistent activation of the immune system in patients with hypercholesterolemia who are treated with statins. Saroen Bekkering, Radboud University Medical Center, Nijmegen, with colleagues from Amsterdam and Rotterdam investigated the activity of part of the immune system in individuals with and without high cholesterol levels. It appeared that specific immune cells in the blood, monocytes, were more activated in patients with high cholesterol levels than in individuals with normal cholesterol levels. These cells produced more inflammatory molecules that are important in the development of cardiovascular disease. Subsequently, the patients with high cholesterol were treated with statins to lower their cholesterol levels, and the same measurements were repeated 3 months later. Importantly, despite cholesterol lowering, the hyperactivity of the immune cells did not decrease at all. Niels Rickson, professor of internal medicine from the Radboud University Medical Center, and coordinator of the project, states that we thus observed that these immune cells appear to remember the high cholesterol they once were exposed to. The finding that monocytes can remember previous exposures has only recently been discovered, and has been termed trained immunity, and this is the first study to demonstrate this in patients. According to Rickson, it would be interesting to investigate now how long this memory lasts, and also whether the hyperactivity of the monocytes can be reduced by other drug types, such as anti-inflammatory drug. Opioid alternative? Taming tetrodotoxin for precise painkilling opioids remain a mainstay of treatment for chronic and surgical pain, despite their side effects and risk for addiction and overdose. While conventional local anesthetics block pain very effectively, they wear off quickly and can affect the heart and brain. Now, a study in rats offers up a possible alternative, involving an otherwise lethal pufferfish toxin. In tiny amounts, in a slow-release formulation that efficiently penetrates nerves, the toxin provided a safe, highly targeted, long-lived nerve block, researchers report today in Nature Communications. The study was led by Daniel Kohane, MD, PhD, director of the Laboratory for Biomaterials and Drug Delivery at Boston Children's Hospital. Kohane has long been interested in neurotoxins found in marine organisms like pufferfish and algae. In small amounts, they can potentially provide potent pain relief, blocking the sodium channels that conduct pain messages. Kohane's lab has experimented with various ways of packaging and delivering these compounds in tiny particles, activating local drug release with ultrasound and near-infrared light, for example. For the new study, the team chose tetrodotoxin, a potent, commercially available compound derived from pufferfish. Tetrodotoxin is notorious for causing fugu poisoning from improperly prepared sashimi. Taming a lethal toxin. Rather than load tetrodotoxin into particles as before, the team bound it chemically to a polymer backbone. The body very slowly degrades the bond between tetrodotoxin and the polymer via hydrolysis, the natural breaking of chemical bonds by water. This releases the drug at a slow, safe rate. A lesson we learned is that with our previous delivery systems, the drug can leak out too quickly, leading to systemic toxicity, says Kohane. In this system, we gave an amount of tetrodotoxin intravenously that would be enough to kill a rat several times over if given in the unbound state, and the animals didn't even seem to notice it. Kahane's fellows, Chao Zhao, Ph.D., and Andong Lu, Ph.D., experimented with different drug loadings and different polymer formulations to get the longest possible nerve block with the least toxicity. We can modulate the polymer composition to control the release rate, Zhao explains. Enhancing permeation. To further increase safety, the team paired the tetrodotoxin polymer combination with a chemical penetration enhancer, a compound that made the nerve tissue more permeable. This allowed them to use smaller amounts of tetrodotoxin but still achieve nerve block. With the enhancer, drug concentrations that are ineffective become effective without increasing systemic toxicity, says Kohane. Each bit of drug you put in packs the most punch possible. We show that both the penetration enhancer and the reversible bonding of toxin to polymer are crucial to achieving such prolonged anesthesia, adds Lu. Good early results. When the researchers injected the combination near the sciatic nerve in rats, they achieved a nerve block for up to 3 days, with minimal local or systemic toxicity and no apparent sign of tissue injury. In theory, nerve block in humans could last even longer, since one could administer it more safely than in rats, says Kohane. Using polymers with a longer retention time in tissue would also prolong effects. We could think about very long durations of nerve block for patients with cancer pain, for example, he says. Certainly for days, and maybe for weeks. Human protein that aids development of malaria parasite. Identified researchers in Japan have discovered that the Plasmodium parasites responsible for malaria rely on a human liver cell protein for their development into a form capable of infecting red blood cells and causing disease. The study, which will be published June 12 in the Journal of Experimental Medicine, suggests that targeting this human protein, known as CXCR4, could be a way to block the parasite's life cycle and prevent the development of malaria. According to the World Health Organization, there were an estimated 219 million cases of malaria in 2017, resulting in the deaths of approximately 435,000 people. Infected mosquitoes transmit Plasmodium parasites to humans in the form of rod-shaped sporozoites that travel to the liver and invade liver cells, hepatocytes. Once inside these cells, the Plasmodium sporozoites develop into spherical exoerythrocytic forms, EEFs, that eventually give rise to thousands of merozoites capable of spreading into red blood cells and causing malaria. It seems likely that the transformation of Plasmodium sporozoites into EEFs is tightly controlled so that it only occurs in hepatocytes and not at earlier stages of the parasite's life cycle, says Masahiro Yamamoto, a professor at the Research Institute for Microbial Diseases of Osaka University. However, we know very little about the host factors that regulate the differentiation of sporozoites in infected hepatocytes. In the new study, Yamamoto and colleagues discovered that a hepatocyte protein called CXCR4 helps Plasmodium sporozoites transform into EEFs. Depleting this protein from human liver cells reduced the ability of sporozoites to develop into EEFs. Moreover, mice pretreated with a drug that inhibits CXCR4 were resistant to malaria, showing reduced levels of parasites in the blood and significantly higher survival rates following Plasmodium infection. Yamamoto and colleagues also identified a cell signaling pathway that causes hepatocytes to produce more CXCR4 in response to Plasmodium infection and determined that the protein aids the parasite's development by raising the levels of calcium inside the cells. Our study reveals that CXCR4 blockade inhibits Plasmodium sporozoite transformation in hepatocytes, Yamamoto says. Most anti-malaria drugs targeting Plasmodium-derived molecules eventually lead to drug resistance in these parasites. However, inhibitors targeting human proteins such as CXCR4 might avoid this problem and could be used prophylactically to prevent the development of malaria. Moreover, the CXCR4 inhibitor used in this study is already widely used in humans undergoing treatment for blood cancers, which could accelerate its repurposing as a new way of combating malaria.